I'm just going to now introduce Dr. Joanna Chu from the Auckland Centre of Addiction Research at the School of Population Health. So Joanne is a Senior Research Fellow at the School of Population Health, as I've just explained. It's a bit of a mouthful, isn't it? Because it's under the Faculty of Medical and Health Sciences and the Centre of Arts and Social Transformation, Facility of Education and Social Work. How do you write that in the bottom of your email flyer? She holds a postgraduate qualification in psychology and earned her PhD from the University of Auckland. She's a recipient of the Heart Foundation Fellowship. Previously, Joanne worked as a postdoctoral research fellow at the School of Public Health, University of Hong Kong, and was involved in a number of community-based projects aimed at building community capacity and improving family-related outcomes. Joanne has worked with government agencies, non-profit organisations, schools, and co-developed practical and innovative programs to meet the needs of targeted populations. Her current work aims to address health inequality in New Zealand and is guided by the principles of Te Titi o Waitangi. Joanne has a genuine interest in child and adolescent wellbeing and has a solid background in developmental psychology, digital health, family intervention, fetal alcohol spectrum disorder, and community-based participatory research methods. It goes on and goes on. Would you mind joining us? And I just ask the audience just to welcome you with a round of applause.
I did not realise when I wrote the bio that it was that long, so yes, there was more, I think. But, so thank you for having me here. It's a privilege to be here. It's quite a bit of pressure having to speak after two great speakers, so do bear with me. I always think of coming to a FASD symposium or FASD presentation. It's always like coming back to an extended family. It's always been really welcoming, and this is what keeps me in this space. So just a little bit about myself. I am a Senior Research Fellow at the University of Auckland. I was going to say Hong Kong, but I was originally born. Well, I was born in Hong Kong, and I came here in New Zealand with my family when I was 7. So I've been here pretty much in Tamaki Makaurau for most of my life. I have 2 kids that were born here. They're a 6-year-old and 3-year-old, which keeps me really, really busy as well. But I remember coming into this space when Professor Chris Bullen asked me at the time, around 4 or 5 years ago, are you interested in FASD? And I said to him at the time, I have no idea what FASD is. Although I had my training in psychology and also my PhD in education, I remember very little around training anything or learning anything about FASD. But for the last 4 or 5 years, it's really been a privilege to be able to be researching in this space. And I always say it, and I'll say it again, but it really is the people, the amazing people, the privilege to be able to hear all the lived experience, the people that have shared just being so generous with their time and experience and expertise, and sharing a lot of that with me. So again, it is what really keeps me going, and it is, when you learn about how under-researched, underfunded, underserved this FASD community is, you really do feel responsibility to make more and do more in this space, and this is why I'm here. So very happy to be here, and again, thank you, Andrew, for organising this amazing symposium, and to see the momentum behind this is really, really exciting as well. So, the red? Nope, green. So I mean, every one of you will probably know what FASD is, but I do just want to, for those perhaps less, this is the common definition that we use for fetal alcohol spectrum disorder. And as you have heard, it is a diagnostic term used to describe the impact on the brain and body of individuals prenatally exposed to alcohol. As you have heard, it is a lifelong disability, and individuals with FASD will experience some degree of challenges in their daily living and need support with motor skills, physical health, learning, memory, attention, communication, emotional regulation, social skills to really reach their full potential. It's also really, really important, and I think as you have heard from Claire, they're also unique people with FASD is unique and has areas of both strengths and challenges. And often we do focus a lot on their challenges and forget about their strengths. So it's really, really important that we do remember that as well. And so just some really diagnostic terms. Perhaps everyone knows more than me already, but just a little reminder that there have been different terminologies that have been used over the years: fetal alcohol syndrome, fetal alcohol effect, partial fetal alcohol syndrome, alcohol-related neurodevelopmental disorder, and also now we use FASD as sort of an umbrella term in international literature to cover the range of spectrum of FASD. As you have already heard, we don't have a prevalence study in New Zealand. The recent study conservatively estimate that the prevalence of FASD in New Zealand is at around 1.5%, with an estimated prevalence of 2.1% in Māori. The Ministry of Health estimate between 3 to 5%, and that's as many as 3,000 births each year are affected by prenatal alcohol exposure. It's also likely more common than autism spectrum disorder, Down syndrome. And we also know that in particular populations, there are a much higher rate of FASD. So for example, in Australia, in the Banksy Hill study, which was a youth detention centre, they found 36% of those in the youth detention have FASD. And so when I started back in about 4 or 5 years ago, this was the really first piece of work that we undertook. And it was about establishing research priorities from those with experience or expertise of FASD. And we know that it was a really underfunded and under-researched space. And so one of the first things that we really wanted to do is, in this environment or in this area, what were the research priorities? What were the community wanting us to research on? And so this was one of the first and really important step for us, because it's guided all the subsequent research that I've been doing in this space as well. And this was a piece of work that was co-led with Hapai, back then with Janelle Dimers, who I think many of you might know, Janelle. It's also supported by Dr. Andre McLaughlin, which I think many of you will know as well. Dr. Jessica McCormick, Dr. Samantha Martin, also Associate Professor David Newcomb. Just also to acknowledge that this piece of work was funded by the Health Research Council. And so we invited whānau and caregivers of individuals living with FASD or suspected FASD to participate, health workers, support workers, social workers, and other front-facing staff involved in the care of people with FASD. Also invited educators, clinicians and researchers with an interest in FASD or working with people with FASD. We were constrained by our budget, so in terms of we wanted to invite people across nationwide, but we only delivered Hui in the North Island and between 8 to 18 participants in each of these Hui. We also offered interviews for those that couldn't make it to the Hui, and the Hui was facilitated by Andre and also Jessica at the time. I do have to put a disclaimer in there that we received the funding and then I went on maternity leave. So I cannot claim any credit in terms of doing this piece of research, but really, really acknowledging the work that Andre, Jessica, and the rest of the team, and also everyone that has been involved. So I am a researcher, so I do put numbers. So we had research, those in the research clinical, those as families, those as educator, or those that worked in the health professionals. So there were over half of the participants were Māori or identified as Māori, and also many of them had many experience with FASD. And I think it's really also important to acknowledge that many participants indicated that they didn't just belong to a single group, but rather they could be a worker, a health worker or health professional, but also as a whānau of someone with FASD. We weren't able to recruit any participant that identify as biological parents, and I think this is always the case in FASD research. It's really difficult to invite biological parents to participate in the research space. In terms of findings, we identified 20 research priorities from the Hui interviews, and these, as you'll see a bit later, these were really, really broad research questions as well. And the priorities were classified into sort of the following categories. So what were the research that we want to do in the system? What were the research that we want to focus on in terms of our workforce and community? And what were the research priorities for whānau members or those living with FASD? So, I know this is a bit small, but I will go through them. So again, these were the kind of really 20 broad research questions that we had. And under the whānau, the Hui, there were lots of, and I think many of you actually participated in the Hui back at the time as well. So there were lots and lots of rich, really, really rich conversation, really rich information that was shared with us. And particularly for individuals or whānau, it really focused on, what are the factors that actually determine the consequences of prenatal alcohol exposure? So it also came back to questions around the prevention, also questions around intervention, and so how does the diagnosis of FASD impact the whānau of people with FASD? What factors can be used to support whānau decision-making around alcohol use in pregnancy? What does FASD look like across the lifespan? Because we know there are a lot more research done in the children and teenager space, but a lot less for the adult space. What factors can be used to support whānau of people with FASD in their roles as carers? So again, even as you see, these questions in itself are broad and very, very big to address. We also had a number of research priorities that came up from the workforce and community. So what does the frontline workforce know about FASD? What does the frontline workforce or community need to support people through alcohol-free pregnancy? What support can we provide for mothers during pregnancy to support with alcohol dependence? How do we identify effective evidence-based intervention for FASD? What could Papamarima approaches are existing within health, education and social sectors that can be applied to FASD intervention and assessment? We need to understand the attitudes towards FASD. What are the public attitudes towards FASD? What are the professionals' attitudes towards FASD? And also understanding the attitudes towards prenatal alcohol exposure as well. So really around the prevention and also the intervention space. And then a lot of questions around the research priorities around the systems. What can we actually do to encourage success for people with FASD throughout their lives? What is the cost of FASD to society? What is the prevalence? What are the incorporation of FASD information into school and health and education? How do we establish consistent messaging around pathway to diagnose and intervention for people with FASD? How do we explore the inception of alcohol into Māori culture? Understanding how the New Zealand drinking culture and alcohol environment contributes to FASD, and also what are the barriers to recognition and support for people with FASD. Again, each of these probably require a PhD to undertake that piece of research. So again, anyone that's interested in research, we're always welcome in this space as well. There's just so many questions that needs to be answered and researched. So of those 20 research priorities that Janelle and also Jessica at the time analysed and came up with, we also sent these research questions back to our participants to really identify if you had to rate each of these research questions on their importance and relevance, and also select the 5 most important questions to you from that list of 20, what would be your top priorities? And I mean, again, it's very small, but I will go through them. It's not a lot of difference in terms of, many of them were important and really, really relevant to everyone. But it really came down to really small difference, but these were really the top research priorities. What can we do to encourage success for people with FASD throughout their lives? And this is across the lifespan. How can we better support people and family across the lifespan? We need to develop a FASD-informed workforce, and this range from not just the justice sector, health sector, is also around the education sector. As you have heard from Claire and others, this is a cross-agency, and it affects all the sectors around, and we really need that cross-agency kind of approach. And the need for information on prevalence to inform policy. And I know many of you, and many before me, have really advocated for a prevalence study, which yet to be happened. And we also identified, particularly for Māori, it was around the need to identify existing kaupapa Māori approaches that could be applied to intervention assessment of FASD, and also really developing the kaupapa Māori interventions where those were absent. And I do want to go on to talk a little bit about the subsequent work that we have been doing, and those research priorities really drove a lot of the subsequent research that we have been really focusing on. And one of the ones that we have really led around is around the knowledge, attitudes and practice surveys around a lot of different sectors across education, social, health and justice. And so we focused on questions around, what is our workforce in terms of awareness of FASD, knowledge and beliefs about FASD, the impact of FASD on professional practice and experience with FASD, and the training and the information needs relating to FASD. And I don't think any of these findings are surprising to anyone here, but out of the 662 participants across the sectors, across different sectors, we find around 50% reporting really basic understanding of FASD. Almost 40% reported that distinctive facial feature is a requirement for FASD diagnosis, which we know that's not true because only around less than 10% actually present any facial kind of features or physical features. And so this really does act as a sort of a barrier to, and this is why FASD is often known as a hidden disability or invisible disability. But yet, out of those 662 participants, 76% reported FASD as being highly relevant or relevant to their work. But again, very alarmingly, only 5% felt very prepared to work or support an individual with FASD. And I think often, as we have already heard, the stories or the lived experience of people or even the voices of people are so important. And I think, I want to finish this presentation with a lot of the quotes that have come from educators, health professionals, lawyers who participate in the survey and share their experience with us as well. And I think this really does kind of summarise, the state of our workforce as well in terms of the challenges that they are facing as well. So the lack of funding as children with severe behaviour are only entitled to one term of teacher aid support. After this, it is an intensive wraparound service application. And again, children, young people have had to present with severe behaviour and poor attendance. There are again funding restrictions. There are no specific agencies that alone will support funding unless you have an IQ diagnosed. And we know that unless you have an IQ of less than 70, you're not able to access the disability services. And so many of our whānau do not cope with the level of hoops they need to jump through to gain the support. You also need to invest the time to develop a strong relationship with the whānau, and with high caseload numbers, this is really challenging. And so this came from a quote from an RTLB that works in the education sector. We also had a teacher aide that shared with us, at my last school when I was a teacher aide, we had funding for 2 kids with FASD, but they only got the funding for being dangerous to others in the playground and then for help with their learning. The effort to get funding and provide enough support is the biggest problem. Teaching in a classroom of children with incredibly different needs is so challenging, and these kids take up a lot of your time. It's sad because you want to do what's best for them, but you end up being very, very frustrated. We also have other health professionals, which you will also hear a bit later in our quickfire research. Isaac will talk a bit around what the health professionals say. So this DHB, sorry for the swear word in there, but this DHB does not have a service or recognise it as in the Paediatric Disability Service. Many doctors do not believe it is real and call it a bullshit label to be used as a catch, or that do not fit real diagnoses. And I think this is very common and something that we hear a lot. My team do not know much about FASD, let alone how to work with people who have FASD, and so this is a huge challenge. It was heartbreaking to watch a young man who has FASD be stripped of his assistant in supported living when someone assessed him as no longer qualifying for his autism diagnosis. The assessors still say he had FASD, but the disability support didn't acknowledge that it's his disability, so his funding was withdrawn. That was pretty scary for a young man who had spent all his adult years in supported living with significant difficulties